have a lack of specialists in the private sector, and those who are in the public sector employed by the state would then render those services outside. So the policy has been a long-standing practice among healthcare professionals, offering benefits as additional income, diversification of skills, networking opportunities as well. However, it also raises important ethical concerns. We know this. How do we balance our public sector responsibilities as doctors and as practitioners in general with our private interests? How do we ensure the equitable service provision and prioritization of patient care? And what are the implications for the integrity of the public health system with the RWOPS system? So today's panel discussion is going to tackle this complex issue. We will explore the advantages and the disadvantages of the RWOPS. We will examine the impact on our well-being as professionals, and we will also evaluate the ethical implications of this practice. We will also just discuss potential regulatory frameworks for governing RWOPS and explore alternatives that uphold ethical standards and prioritize patient care. So through this webinar, the South African Medical Association hopes to spark a thoughtful conversation about the role of RWOPS in our healthcare system. And we hope that we'll be able to work together to ensure that our professional practice align with our values as medical doctors and a commitment of delivering quality healthcare to our patients. So we do have a number of panelists with us today. I'm going to hand over to them to introduce themselves. We'll start with Ms. Mashego. Thank you very much, ma'am.
Thank you, Program Director. Good evening to everyone on the call. My name is Pleasure Matsego from the Department of Public Service and Administration. Since 2019, the President promulgated a unit called Public Administration, Ethics, Integrity, and Disciplinary Technical Assistance Unit. I am one of the directors in the unit. My responsibility is setting norms and standards regarding ethics, integrity, and conduct management in the public service. Thank you, Chair.
Thank you very much, Ms. Mashego. Can I then hand over to Dr. Nkwinta?
Thank you, Chair, and good evening to everyone. I am Nyaziwa Kwinda. I am a medical practitioner, a specialist in family medicine, but with special interest in bioethics and health law, with an MSc Med in bioethics and health law with Wits University Steve Biko Center for Bioethics, but also an LLB. And I am here not only as a summer board member, but as an expert in bioethics and health law. I am currently the Chief Executive Officer for Siamiso Trust. Thank you, Chairperson.
Thank you very much, Dr. Nkwinta, our member of the board of the South African Medical Association. So colleagues, with us, we're also going to be joined later or just a few minutes from now on. Oh, yes, I think we've just been joined now by Mr. Russell Rensburg, who is a director at Rural Health and Advocacy. I will hand over to you, Russell, to introduce yourself, please.
Thank you, Doctor. Hi, good afternoon or good evening, colleagues. I think it's a great pleasure to be with you on this webinar on this very contentious topic. My name is Russell Rensburg. I'm a health activist, and obviously I advocate for equitable access to... Okay, let me turn on my video. So you can see. There we go. My name is Russell Rensburg. I work at the Rural Health Advocacy Project. Our objective is to advocate for access to quality healthcare services for rural communities. And we do this by connecting policy and practice. Our primary focus as an advocacy organization is equitable access to the equitable distribution of human resources for health to meet the rural intent, to monitor implementation, which is particularly looking at governance. And then thirdly, our component is equitable health financing, right? So the money that we do use or do allocate or does get allocated is used effectively and equitably. And yeah, we come to this conversation with great interest to learn more and to understand the way forward on this policy and its potential impact on the rural health provision. Thank you. I don't hold a medical degree. I'm not a medical officer. I'm just a professional advocate. I have quite my expertise is in public finance and in health use and health delivery in South Africa. Thank you. Over.
No, thank you. Thank you very much, Mr. Russell. We really appreciate your participation here. So we'll kickstart our discussions, colleagues, with just asking Ms. Mashego to just give us an overview of the objectives of the RWOPS policy. Over to you, Pleasure.
Thank you very much. After your sterling introduction, you have actually captured the objectives very well, but I'll go through them for the benefit of everyone who has joined later. And I'm going to restrict myself to the healthcare sector because that's what we are. Well, that's the subject of the discussion tonight. So the objectives of other remunerative work in the health sector was to, firstly, it was focused on professional development of employees, providing employees with the opportunity to practice certain procedures, for an example, which they would not normally do in the government facilities and vice versa, but also to share professional experience, especially where doctors or even nurses are involved in training sessions or training upcoming professionals. So it is an opportunity for them to share even practical experience. And thirdly, to enable professionals to undertake academic research in their fields of operation. And lastly, to supplement income. But it looks like the last one is now the priority in terms of the objectives. I think other remunerative work is now more of an income generating activity more than the other things. But I'm open to being swayed by the discussion here. That's how I view it at this point. Thank you very much, Program Director.
Thank you very much to you. Thank you very much to you, Mashego. I just think that the second part that we must deal with is how this policy has been experienced. Maybe at the level of the people who receive the services from us. And I think maybe Russell could come in with a perspective there from his advocacy work. Just the experience of the policy, if any, Russell, that you and how it has impacted your work as an advocacy champion. Thank you.
I mean, I'll probably start then premise the conversation to say that, look, as South Africans, we sometimes underestimate or undervalue what we have as a country, right? I think we're one of very few countries on our continent that have access to universal healthcare on a publicly funded platform, right? We have access to it, but not necessarily service coverage, right? And over the last at least since 2015, we've had a rapid expansion in capacity. I think currently we're producing close to 2,500. And when I say we as a collective, us as a country, I think medical universities heeded the call, right, to increase training numbers. And we have every year at least 2,500 new medical graduates that need to be absorbed into the system. But underneath that, I think the biggest challenge that we have with RWOPS in particular is the lack of information. And it's difficult to assess the impact or to come up with a reasonable policy response to it without data. My understanding of the policy was that it was written for all public sector workers, and there wasn't a specific policy or RWOPS policy for health in particular. And the guidelines for the professional engineers, lawyers, and educators who are also covered by this policy are almost less clear. Or generally, the policy is opaque. And when the policy is opaque, it's difficult to implement it. When it comes to healthcare workers, I think one of the challenges is that remunerative work outside of public practice or public service is exactly the same work being done within the public service. So there's a bit of a conflict underneath that. So which work do you choose to do in your private practice, and which work do you do when you're in the public service? There's no clear direction on what percentage of time can be utilized for remunerative work outside of the public service. So I think it's more an ethical dilemma more than anything else, right? Are we getting good value for our money as a country? Are we getting the right kind of service from our professionals? And really, I might want to cluster all professionals in the same bunch. But we know from reports from the Board of Healthcare Funders and so forth, that sometimes the claims from people who are currently working outside of the public service while employed in the public service is higher than people that are 100% in private practice. So where I'm at, I think the way out of this issue is better recognition of the contracts, a more open transparency of who has been authorized to work outside of the public service. Because the impact is less on patients and more on the doctors who do not operate RWOPS. We know, for instance, there are reports, and I get this anecdotally from a lot of doctors that we interview, suggesting, that whoever doesn't pitch up or complete their allotted hours has a negative impact on those dedicated workers who stay in the system, right? And they end up taking on a greater burden, and a greater burden means more hours. More hours means a greater possibility of medical errors and so forth, and really can also have a negative impact on the well-being of the healthcare providers that are so important in the journey to expand universal health coverage. So the impact on patients, in short, is really difficult to assess. But I think the impact of unmanaged or poorly managed RWOPS is much bigger on the broader population of healthcare workers within the public service. And I think that an injury to one is an injury to all, and we need better fairness and better balance, because unfortunately the patients in this instance have to just take what they get, right? And in the absence of transparent information, we don't know. But I think the greatest impact is on healthcare workers, and mostly on those who don't do remunerative work outside of the public service, right? And I think that's something that we probably need to delve in deeper. If we're going to run with it, how do we govern it better? How do we ensure that people apply for the necessary authorities? And if people are doing unapproved work, what is the censure? And what is the role of the profession in ending the abuse of RWOPS? Because if it's unauthorized, it's essentially theft, because you're being paid for doing the same thing twice. And that's not ideal. Over.
Yeah. No, thank you very much, Mr. Russell. I really appreciate your interventions there. And talking to the issue that relates to ethical issues, we will get to that just quickly. But because we really would like this type of webinars to be interactive, so I'm going to just quickly squeeze in a quick question from Timothy that I think Mashego can deal with, and the other colleagues. So Timothy Hardcastle is asking here, Mashego, that For him, the big question is actually what constitute RWOPS for medical professionals. Is it anything you earn over your salary, or is it only clinical work? So there's a clear question there. And then he goes on and make an example to say, my hospital requires me to register for RWOPS to be able to examine thesis and do journal work, which is related to my profession, some of which pays honorarium rather than a salary. And then does RWOPS actually include all of these aspects, even if we are joint academic staff of our affiliated universities, who otherwise do not pay us? So there is a specific question there, Mashego, which I don't know with the other panelists if you can help Timothy to answer that. Thank you very much.
Thank you very much, Program Director. To respond to Timothy's question, other remunerative work, it's actually called other remunerative work. So it is work for which you are remunerated, and that does not include the work you do in the department. It doesn't include the work that forms part of your performance contract. So it will not only be clinical work. Nowadays, I even see health professionals are involved in other businesses other than within the health sector. They run construction companies, they run beauty salons, and all the other things that they are able to do. So any work that you do outside your department and you are being remunerated for, it's other remunerative work, and the employee is expected to apply for other remunerative work. Now, towards the end of the question, you mentioned something like the partnership that you would have with universities for research and the like. So in an instance where an employee is doing work on behalf of the department and that work is not paid, that would not constitute other remunerative work. So if for an example, in partnership with the hospital, the academic hospital and the university, you are undertaking research and Dr. Timothy is the supervisor of the students, that work is not paid for, it's not a private work, it's the arrangement that we have. Even the CEO of the hospital knows that this is what Dr. Timothy is involved in, and he has been given time in the department to do that particular work, and he's not going to be remunerated privately for that. That will not constitute other remunerative work. I hope I've answered, but if there's a follow-up question, I'll be glad to take it.
Yeah, no, thank you very much. Pleasure. I really appreciate that. So I think now let's just move on.
And you can continue to call me Pleasure.
Okay. Right. So let's just deal with the ethical considerations just around the RWOPS issue. So I'm going to call in Dr. Nkwinta here to give us just the ethical considerations that you believe are associated with RWOPS, and particularly in terms of the conflict of interest when it becomes between, as it relates to actually patient care. So, Dr. Nkwinta, if you may, just take us through the ethical considerations here. Thank you very much.
Thank you so much, Chair. In addressing this, if you can allow me, and I will also use my space as a board member as well, because with some of the work that I have done from a research point of view, I will agree with Pleasure in terms of the objectives of RWOPS, except that is what she has described, the way she went about it and putting or placing the issue of financial need or objective at the end. That is for developed countries. Yeah, for developed countries, you can say that. But when it comes to first and second world countries, and this is from evidence point of view, with countries like ours, that last objective, in fact, is the first one due to the low salaries in the public sector. So many doctors who do remunerative work outside public service is not necessarily for development. It is basically to supplement low incomes from the public sector, whereas with developed countries is the other side. Now that becomes very important when you come to the issue of the ethical consideration, but you cannot talk about ethical consideration of RWOPS without first looking at the legal consideration. The reason being that RWOPS does not start at a policy level. RWOPS is contained in the Act of Parliament, which is the Public Service Act. And that is where we need to start, because there you see what is the obligation of the public servant who want to perform RWOPS, and what is the obligation on the other side of the members of the executive in terms of approving or not approving. And that is where issues start. When you start there, when one applies to do RWOPS in terms of Section 30 of the Public Service Act, and the executive authority or whoever is delegated with that function approves that RWOPS, there are conditions under which that RWOPS is approved. In other words, it is known by the employer what that RWOPS is going to involve, when is this public servant going to perform that RWOPS, and that will dictate how that RWOPS is managed. And from an ethical point of view, that is where you start. What was the agreement between the employer and the employee? And following that, Section 31 of the Public Service Act even states how, if there is an abuse of RWOPS, that is supposed to be managed. It's quite very clear in terms of the Act. It even got to a point of saying that public servant then must return the money back to the National Treasury if they have done RWOPS without approval or outside the conditions of approval. So that is where we start in terms of RWOPS. So already you can see that there is a duty on the side of the employer as well in terms of the approval conditions. Now, when you come to the ethical aspect of it, now we need to start by understanding that doctors are professionals. And that is where everything starts. I want to go back to the issue also of what remunerative work comes from. It becomes very difficult when you talk about remunerative work outside public service and you have to talk about selling tomatoes or all the other things that anyone can do. You can see already that can take you too far. And unfortunately, the focus currently of RWOPS is mainly on health professionals. And I'm saying it now from the department's point of view, mainly health professionals, because of the impact that it has on the patients. But you still have non-health professionals who are selling perfumes in the hospitals and no one says anything about it. Others are selling Tupperwares in the hospital. Even managers buy Tupperwares from them. There is no issue. But from a professional point of view, where we start ethically is because there is something that is expected in terms of how a professional handles themselves. Now, there are duties that are imposed on a professional just by being a professional. First, of course, before you become a professional, there are natural duties just because you are a human being. And when we come to a professional point of view, although we don't say much in terms of virtue ethics nowadays, but still there is an element that is important there, that what is expected of a professional is a virtuous person, a person of integrity, a person who is honest in whatever they do. So that is what is expected of us as health professionals. Now, when we come now specifically to the ethical principles, we know you need to act in the best interest of your patient, and that is how you will be judged. When you do what you are doing, are you acting in the best interest of your patient? Now, it goes back to the issue of the harm that can happen because you are not there when you are not supposed to be there. We go back again, when you talk about duties that practitioners have, they've got legal duties and duties that they have towards their employer. From the Basic Conditions of Employment Act, you contract to do 8 hours of work per day. Are you doing those 8 hours per day, or you are doing fewer hours? Research has already shown, and I think there's a report from the Public Service Commission that demonstrated that doctors are in fact working 4 hours in the state and the rest of the hours working in their private practices, but the state still pays them for 8 hours while they've worked 4 hours. That is unethical. When you look at the guidelines of the HPCSA, there's a guideline on perverse incentives that clearly captures this. And when I was at the HPCSA, of course, we also included something about dual practice in those guidelines, just to bring some guideline in terms of remunerative work outside public service, because it's also known as dual practice, which basically specifically focus on your clinical practice between public sector and private sector. So perverse incentives is that money that, or any remuneration that you will get illegally. So if one is making money during the time when they are supposed to be working for the state, and they are also getting money from the state that they did not work for, that is unethical. That is a perverse incentive. So there are lots of issues. Let's go back to the principle that deals with, are you using the state as a means to an end, or the state as an end itself? That is Kant now, where now doctors are getting paid by the state but not working for the state. That becomes unethical. So those are some of the unethical issues that comes into RWOPS. But Chair, as I conclude, I think it's very much important to come back to the issue of dual practice is more clear than just saying RWOPS, because it talks about your clinical practice in the state vis-a-vis your clinical practice also in the private sector. Thank you.
Yeah, no, thank you very much. Thank you very much, Dr. Mnyadziwa. I really appreciate those inputs. I see Russell wants to come in. Russell, just before you come in, I want to squeeze in just 2 quick questions that the panelists can think of. Colin is saying, fine, there are huge benefits to all with RWOPS. That's okay. But the question that is posing is that how well are students learning in our teaching hospitals when many of the relevant teachers are AWOL working in private? It touches on the ethical issues. And then Michael Zuckerman is asking there, Michelle is asking, how do we control RWOPS? How do we, as a profession, how do we control RWOPS? In her experience, private patients take priority over public sector patients, and in public sector, other colleagues pick up the slack, like you've indicated there, Russell. And frequently, these are junior colleagues, and this normally works to the detriment of the patient. So as you come in there, I think with the things that Dr. Mnyadziwa has also mentioned. So just take us through that, because I think towards the end, we need to start looking for solutions. Thank you very much.
Well, I suppose accountability for what, right? And firstly, I want to obviously reject the idea that public sector wages are lower, right? We went through a whole exercise in 2009 as a country with the introduction of the occupation-specific dispensation. And I think it contributed to at least a 15 to 20% increase in what we paid public sector workers in designated professions. And I think really comparatively, what we pay medical officers in the public service compares quite favorably with what is paid in jurisdictions like France and the United Kingdom, right? For doctors and junior doctors in particular who work in the NHS. And I don't think that RWOPS is essentially should be motivated as rewarding a profession, because I think for their particular expertise, but I do think we need to sort of debunk that myth that South African healthcare workers are underpaid, because I think we have addressed that issue as a country with the introduction of the occupation-specific dispensation. The second component and the ethical dilemma for me is more importantly that the whole process of RWOPS is premised on asking for authorization, so that the facility that you work in can have an understanding of what other interests you have. I don't think it's got anything to do with selling Tupperwares and X, Y, and Z, right? Which I think is meaningful, but I do think that professionals should be kept for a higher standard, because these are highly paid. We see people in the media talking about all the public sector millionaires, and many of them are doctors and specialists who are in the employ of the public sector. And I think those amount to over 22,000 at last count. And there are 40,000 highly paid workers within the health sector. So doctors and specialists make up a large portion of that. But they do deliver an important public service. Right? So I think when it comes to ethics, there's professional ethics in the first instance, do no harm. Right? I think all medical workers sign that. And I think that's the ethical standard that as professionals they should hold themselves by. Secondly, there is the issue of personal and professional development. And I think when we register RWOPS, in particular, it gives the system and the public some insight into how state resources are employed and how, and if doctors apply for RWOPS and they are approved, we also have a sense in terms of how the time is utilized. The problem, however, is that a lot of RWOPS, remunerative work outside the public service is not authorized, right? Which creates a greater dilemma. I think in my earlier pointer, I mentioned something from the Board of Healthcare Funders and some of the findings that they're suggesting that doctors who are in full-time state employ have higher claims than doctors that are completely in private practice. So while I also think I agree with the idea of dual practice and more specific regulations around RWOPS for health professionals in particular, because I think the case is unique. We could have sometimes the threshold for declaring RWOPS is other business interests as well. You know, so whether you have a construction company like Dr. Pleasure noted, or you're involved in some investment activities, all of those things take away from your time, right? And they do take away from your professional focus, right? In terms of the SAMA study, I read that study, right? And again, I don't think that it was robust enough and looked at the broader indicators. So while I think your study says that we haven't had sufficient inflation adjustment increases over the last while to keep track of inflation, I don't think the study makes the case that South African doctors are underpaid, right? And I think there was very little comparison with international standards in that study, but it was a good study, and thank you for that contribution. But I think we do need a much broader conversation around how do we deal with dual practice in an environment where we have, and likely to have, constrained resources for at least the next 5 years, where we need to look at the money that is being invested in publicly funded healthcare is utilized effectively. If we want to increase accountability and governance, it's everywhere where we have to apply it. And if we feel that somehow some professionals or some groups don't need to be accountable to the state if they receive a salary from the state, and I think then we're on a slippery slope. Because if we want to grow as a group, I think everybody has to take the responsibility where they are. And I think my question at this stage is, and I saw it in the chat, is why are other professionals not speaking out about the few professionals that are abusing the process? Right? Is that closing a rank of the professions maybe not counterproductive? You know, should we have greater censure from the health professions councils for whistleblowers who speak out of colleagues who abuse the system and indirectly affect patient care, because we have fewer doctors clocking longer hours, and with that comes the increased incidence of errors, because nobody should be working 12 to 15 hours, right? Even when you train to do that. So I don't think we should skirt around the issue. There is a professional conduct issue that needs to be addressed. I do think that the profession needs to take a greater responsibility, because I think sometimes doctors react better to other doctors and their professional college and addressing some of those issues. But if we keep turning a blind eye to it or try and rationalize it in some way without really rethinking about how we can make it work well, we're just going to make the problem worse. But this is not really a management administrative issue. I think it's a professional conduct issue, and I think it's something that the professions need to lead on. And I think we'll be much closer at resolving it, because the biggest impact are on the professionals that remain and don't participate in RWOPS, right? So I don't think we should abdicate our responsibility as a sector. Over.
No, thank you very much, Russell. I really appreciate that. I'm going to, without wasting time, because I wanted to engage you on the study and do say that we do earn 13% less than what we should. And that study clearly shows that. Yeah, but without wasting time and maybe arguing the point there, Russell, let me hand over to Ms. Mashego. Ms. Mashego, can you just briefly, ma'am, just give us now your perspective on what regulatory measures? I mean, I was listening to Russell, and he talks about what frameworks can we now put in place, if any, that can govern the RWOPS. I mean, what ideas are there, given the abuse that is apparently being highlighted here? Over to you, ma'am.
Thank you very much, Chair. But before I go there, I really want to address the issue that my fellow panelists raised around RWOPS being mainly for income generating. Well, firstly, thank you for confirming it, because that's the experience we're seeing. But that is very problematic, and I'm not going to address I think Russell addressed the issue around OSD and the like. And I just want to say, I think nobody's salary is enough, and nobody will tell you he earns enough. But really, this is an ethical issue, because doctors, other professionals now sometimes have to work longer hours because somebody is on sick leave forever while actually not on sick leave. So professionals abuse the leave system. You find that people in Mpumalanga are doing other remunerative work in Gauteng. So you can imagine if you have 4 days leave, so you're going to spend it in Gauteng working, and on the 5th day you're going back to work. That has implications in terms of the quality of service that the patients are getting. And I can go on and on. I mean, health professionals still medication and other equipment. We've just had a case in Mpumalanga Middleburg Hospital where the doctor was arrested for stealing medical equipment and medicine, probably to use in her private practice. So there are so many issues, ethical issues, and I hope this discussion is saying we want to address these issues also as the medical profession. But when it comes to what regulatory measures should be put in place, I think there is no monitoring of other remunerative work. Firstly, because this is a second income for professionals, they feel entitled to other remunerative work. So even the application process is just a compliance. They don't even expect a no in terms of their application. And I think that's the attitude of I am entitled to making more money on the side while I disregard other responsibilities. So I think some of the regulatory measures that should be put in place as soon as the supervisor supports the employee's application for other remunerative work, that supervisor must also take responsibility for added measures to ensuring that the employee performs his or her duties for which that person is being paid for. Because I don't think it's fair that we pay you for 8 hours, but you only come for 4 hours, as the report that my fellow panelist quoted. If it comes to a point of implementing attendance registers, and I mean in the form of biometrics systems and the like, not because if we sign a register, you just call your friend to go and sign for you. In one report that I think it was a news article, you find that the supervisor is performing other remunerative work and the supervisor of the supervisor is also performing other remunerative work. So it's like we do this, we do that, we agree on how we're going to do that, which is not the right thing. I think there's there should be, I know in 2018, the Department of Health issued a comprehensive policy guideline on other remunerative work for medical practitioners and dentists. And in there, they have already put the limit in terms of hours. I'm not in the medical field, so I don't know what category 3 is and 2, but I'm sure you all understand that, but there's a limit in terms of that. So that those measures should be implemented seriously and taken seriously by the health profession. And added to that, there might be other categories of employees who are not allowed to perform other remunerative work because of their obligations and responsibilities towards the state and ensuring that other employees abide by the rules that are put in place for other remunerative work. Monitoring of leave, both sick leave and annual leave, for anybody who has approval for other remunerative work, should be there should be a strict monitoring in terms of leave of those people, even if it means it should be audited annually. It should be brought for audit so that we clearly are sure that you are not abusing your privileges in terms of having approval for other remunerative work. Russell has already spoken about the whistleblower protection measures, which I think needs to be in place because colleagues know that other colleagues are not coming to work, but they are either afraid to raise that with management because nothing will be done and instead they will be victimized, or because nothing has been done, nobody cares now anymore. So it's as long as I come to work, and maybe I'll raise an issue if I have to extend my hours because Russell didn't come to work. And I know very well the reason why he doesn't want to why he's not at work is because he's performing other remunerative work. Dr. Kwinda also emphasized on professionalism on the part of health professionals, which I think it's a good thing. And I think we wouldn't be having this debate if everybody is taking their ethical conduct seriously. You know, in situations where even other institutions are trying to ensure that for those who are doing other remunerative work with them, they abide by the rules, they get so questioned that they even feel helpless. Take for an example, the board of GEMS, for an example, is constituted by doctors, for an example. But if they come to a meeting and then they are asked for a leave form, it is such an issue. And if you are not at work and the other remunerative work requires you during working hours, you should put on leave. And those are the arrangements that you should have, you and your supervisor should have agreed upon in the first place, because anyway, that meeting is probably quarterly, but maybe there might be other tasks that you need to do as a board member. Thank you, Chair.
Very much. Thank you very much. Pleasure there. And I like the fact that you also acknowledge that there are also gaps in leadership, because I think managers have a responsibility to manage the resources that are allocated to them, and build in internal controls to be able to monitor if people are actually doing the work that they are supposed to do. And one of the simplest things you can just do is to put up an audit team that can then check the hours, because everything that is done privately is public knowledge. The time that you've started cutting in private is public knowledge. So systems can be put in place, just that managers must manage. And you also do find that, in fact, doctors who submit RWOPS, sometimes they are not responded to in time. And the policy allows them that after 30 days of having submitted such a policy and there's no response from their supervisor, they then are allowed, and that sometimes creates conflicts because people are just sleeping on their jobs. So I am going to give Dr. Mnyadziwa a chance, as we are running out of a bit of time. We are left with 13 minutes. So I want to run through the questions as well. Dr. Mnyadziwa?
Thank you so much, Chair. I think colleagues, we need to be very clear. When you speak about OSD and we just put a blanket statement that OSD address the salaries of doctors, that will be a wrong statement to make. And I'm saying this because this OSD that you talk about, Resolution 3 of 2009, I was directly involved in it as a technocrat. So I know everything about OSD. So putting a statement to say that OSD improved the salary of doctors is wrong. If you look at resolution number 3 of 2009, you look at those objectives. It does not necessarily talk about improving the salaries of doctors. So we need to be very clear on that one. I thought I need to make that point. Number 2 is the issue of, do we need extra regulatory measures to manage RWOPS? I will say no. Let's exhaust what we have available. As I said earlier, in terms of the Public Service Act itself, like you said, Chair, if the executive does not respond within 30 days, then that is taken as a permission granted. Now, why would the executive not do their work and respond and set the parameters within which that RWOPS need to be performed? So that is where we need to start. Let's exhaust what we have available. From the government itself, Basic Conditions of Employment Act. I always say to doctors, if you don't have time, 8 hours to give to the state in your day, there are other provisions in terms of the Basic Conditions of Employment Act. You can be on a part-time employment. There's a 6/8, there's a 5/8, there's a 3/8. Why don't we explore those areas for those who say, I can't give 8 hours, I need to do my private work? Let's go to the HPCSA. I mean, if you look at the judgments of the HPCSA, there are those who have been found guilty of unprofessional conduct for abusing RWOPS when they are reported. It's only that the reporting of public sector doctors is quite very low, and I'm speaking from experience, having been ombudsman for the HPCSA for 9 years. The reporting from the public sector is quite very low. And maybe also add, by the way, in terms of ethical rule number 25, that those who don't report other colleagues who are acting unprofessionally or unethical or even illegally, they are also in breach of ethical rule number 25. So they, by failure to report a colleague who is not at work and abusing RWOPS is also unethical in terms of ethical rule number 25. So I just want to put it that, you know, as a profession, we are not saying we frown at those who abuse RWOPS because that is unethical. And we are a profession that is governed by ethical code of conduct. And those who are abusing RWOPS need to be brought to book. But leadership in the public sector must do their job as they are expected to do. Weight must not be thrown on the professionals alone, but those who are tasked with the responsibility to manage must just manage.
No. Thank you very much, Doc. I really appreciate those inputs. I think for me, really, the leadership gap is a problem. So I think I can take just the parting shots from Masego, and I think we can also take the parting shots from Russell before we allow maybe just 1 minute just to talk about what then should RWOPS, should they continue? I think Dr. Mnyadziwa has given a view saying that we must exhaust what is there as a framework first before we can even talk. So I just want to hear your views on this. Do you think we should continue with this framework? And do you agree with the suggestions that are coming in from Dr. Mnyadziwa? Just 1 minute or 2 minutes for each of you, then we can deal with the last questions on the platform. Thanks.
Thank you. Thank you very much, Chair. I think Dr. Quinda indicated that this policy comes from the Act of Parliament, and it doesn't only affect health professionals. So to maybe just say stop it, I think it will be opening ourselves to many legal challenges. I think you have summed it up well. Managers must manage. Nobody should be allowed to sleep on the job, because this thing of deemed approvals, although we have seen a decrease in terms of our statistics, we are seeing that we are having a decrease in terms of the deemed approvals. But even those should not be allowed because what it clearly says is somebody sleeping on the job. And when people have deemed approvals, they take it as if they have carte blanche approval to do anything they want, because they do not have a certificate of approval that indicates even the conditions, which is not necessarily the case. Even if you have deemed approval, you are still not allowed to do other remunerative work during working hours. You do not have permission to not to come to work and do your other remunerative work. So I think it's something that should be managed, and I'm not even suggesting extra measures on doing this. These are the measures that are in place. Supervisors must supervise, managers must manage, leadership, if that if that function is not delegated within the department, the minister or the MEC must within the specified time respond to the employee whether he or she approves the application for other remunerative work. Thank you.
Thank you so much, Russell. Just 1 minute.
Okay. You're giving an advocacy person 1 minute is never a good thing, right? Because you're always going to see, I think the first instance is that obviously, you know, healthcare needs are unlimited. Resources to meet those needs are limited, right? In South Africa, we have a constitutional obligation to take reasonable and other measures to progressively realize expansion of service coverage, right? And we have to do so in limited means. So in part, I think I agree with Dr. Pleasure or Ms. Pleasure. So in the first instance, we need better accountability for all stakeholders. I don't think this is a uniquely management problem, and I think that the profession also has to take some professional accountability, because the abuse of this practice, I think, displays negatively on how the profession is perceived. Right? I think the example of taking 4 days sick leave to work in Gauteng while you are full-time employed in Mpumalanga is an example like that. You know, like Pleasure also said, I think most of us don't have enough money to cover our budgets. And we're having the same argument around financial responsibility or financial obligations when it comes to the review of commuted overtime, which is another thing that is open to abuse. So I agree, stronger management, right? And stronger compliance with existing guidelines. The second thing is, I don't think that the profession should abdicate the responsibility to management, right? I think one of the things that the good doctor mentioned earlier was this difference between compliance and professional self-supervision, right? So if you as a professional, and we have to trust you that you will act in a professional manner, this kind of practice is not in line with professional conduct. So I think a dual approach. Firstly, we need a specific dispensation for remunerative work outside public practice for medical professionals. The current policy covers everybody, and it doesn't consider that medical professionals that operate outside of their public service work are doing the same work that they do in the public service. So there are perverse incentives. So we need a specific policy. That's what I would say. The second thing is we need the profession to speak out on this abuse, because it tarnishes the image of the profession, and it also makes younger people entering the profession overburdened with things that they may professionally not be ready with. Right? I'll close with a comment of a young rural or a young community service doctor looking for an attendant or the person that's meant to be on call to give them advice on a procedure that they couldn't do. Right? That person was somewhere at home, took the call and says, do this and call me later. Right? There was no professional support for that young profession. That specialist that was advising was probably working somewhere else in the private sector, doing something else that demanded or earned him more time. But that support of this young professional was undermined by the poor management of remunerative work, right? And we have these conflicting loyalties. So my suggestion is a specific policy for healthcare professionals, because the remunerative work is in the same space. Secondly, I think we need a greater leadership from the profession to root out this practice, and the two should work together. I don't think we should have a binary narrative that because the government doesn't lead, we should continue to do whatever we want. That hurts the patient. Thank you. Over.
Yeah, no, thank you very much, Russell. And I can't agree with you more there. I think as a profession, we really need to take leadership on this. I think Dr. Nhlakanipho Gumede and I think also Dr. Sillo, they really are asking relevant questions there to say, as a profession, what responsibility do we have, and what is our position as a leader in the profession? So and I think Dr. Nkwinta makes Dr. Mnyanziwa makes our position very clear, that we as a profession, we cannot be found on the wrong side of our ethical responsibility and the oath that we've taken to first do no harm. So we just cannot be found wanting. So I think tonight we've managed to navigate through this complex issue of RWOPS, and maybe just as we prepare to close, Dr. Nkwinta, there's 1 minute left for you to just maybe say your parting shot in this as we close, and we really appreciate the interactive nature in which the participants in the webinar have been asking the questions. I mean, I see Dr. Brian Shazy there talking the same thing that Russell was arguing about. What percentage of management is self-management, though, and what is professional ethics? Where does this fit in? So Dr. Nkwinta, let me then give you an opportunity to say your last words on this, and then we can then close.
No, thank you so much. And I agree with my fellow panel members I need to be very clear that as a profession, we do not condone the practice of abuse of RWOPS. As things are right now, one will say, as currently practiced, RWOPS is mainly unethical and also illegal. In other words, it's ethically and legally unacceptable as practiced right now. And there is a lot that we need to do, not only government, but also us as a professional. Not only a professional association like SAMA, we have got a role to play, but also regulators like the Health Professions Council of South Africa also have got a role to play. And those who are abusing RWOPS are acting unethically, not only unethical, but also we know it's illegal to do so, and they need to be brought to book. Thank you, Chair.
No, thank you very much, Dr. Nkunta. And let me take this opportunity and thank you, Pleasure Mashego. I really, really appreciate you. And I must take this opportunity and thank Russell as well for their inputs. And I really appreciate the work that you've put in to prepare for tonight. And let me also thank the colleagues for participating and really made this webinar very interactive. I don't know if we still have the chairperson of the association with us. If we have you, Dr. Mzukwa, still connected, is it possible that you can thank and close the webinar officially? Thank you very much, Dr. Mzukwa. Okay, Dr. Mzukwa, yes, I see your video is on, but you are muted. Oh, yeah.
Can you hear me now?
Yes, we can hear you, Doc. We can hear you, but your video is not showing.
All right. I'm not sure what's happening with the video, but thank you so much, colleagues, for for this panel discussion. But let me also thank our colleagues for joining this discussion, because I think, like it has been said many times in this webinar, that it is our professional responsibility really to act in the best interest of our patients and of the country as well. In as much as we push as the South African Medical Association, we truly believe that as it was shown in our study, that our healthcare professionals in the public sector are underpaid. We are not apologetic about that, but also it does not mean that because we are underpaid and there are all sorts of challenges that we're facing, then we must abuse RWOPS and also behave in an unethical manner. So I do wish that we don't end this conversation here, but we continue looking for solutions. And also, as the South African Medical Association, we must also take a closer look at this and really guide, our colleagues in terms of, their responsibilities in healthcare. So thank you so much. I wish you all the best, and all of you have a good night. Thank you.
Thank you. Goodbye, colleagues.
Thank you very much. Goodbye.
Bye.